Good afternoon, ladies and gentlemen. I'm Dr. Bram Lim from Taiwan Universal Eye Center. It's my pleasure to share with you my experience about the Lentis Mplus. Before demonstration, the surgical management of difficult cases by using the Mplus, I would like to offer some simple, quick and safe way to deliver, rotate, and align the Mplus. In Taiwan, there are two kinds of injectors for Lentis Mplus insertion. Viscojet system from Medicell is a 1.8 mm injector. This injector can insert the Mplus directly into the capsular bag. Combo Trimo from RET is a 2.2 mm plunger type injector. Use the combo Trimo to insert Mplus through a 2.2 mm femtosecond laser incision. Then, press the haptic into the capsular bag. By using the Viscojet injector, we can insert the Mplus through a 1.8 or 1.9 mm clear cornea incision directly into the capsular bag easily, including the leading and trailing haptics. About the Lentis Mplus rotation, many surgeons in Taiwan consider rotating the Mplus to the manufacturer's recommended position near segment at inferior is the most difficult step. However, whether we rotate the Mplus from the main wound or from side pore, we can use many kinds of instruments like white pusher and several kinds of IOL manipulators, such as laser, Cookland, Sinski, and so on. Most of the surgeons rotate the Mplus directly across from the main wound by using white pusher and Cookland manipulator. We can also rotate the Mplus from side pore immediately after IOL insertion. We shall skill at rotating the Mplus clockwise or counterclockwise according to the right eye or left eye. I can even rotate the Mplus from side pore by using my phaco splitter, phaco cleaver, and phaco chopper. Lentis Mplus alignment is another key point. There are several methods that can assist us to align the Mplus. Of course, we can use traditional manual corneal marking under sedum before the surgery to align the axis we plan. Now we can use centration mode of the image-guided system to align the horizontal axis. Besides, we can use toric mode of image-guided system to set any implantation axis we plan to align. For example, 6 degrees in this case. Personally, I prefer to use digital marker, especially when I use a Mplus toric lens. In this case, the implantation axis is 81 degrees. Sometimes we found small amount of misalignment occurred after hydrocele. We can refine the axis from the side pore. Even in Lentis and F15, we can use IA tip or any kind of ground tip to press and tilt the IOL body to see the TD marker by reflected light. Next, I'm going to show surgical management of difficult cases by using the Mplus. The first case is a 58 years old high myopic patient with -18 diopter. She underwent vitrectomy for retinal detachment 1 year ago. The actual length was greater than 32 mm. Pre-OP BCVA was 0.3. After performing femtosecond procedure, first, make sure the CCC is completed. I perform hydrodissection by using a 27-gauge cannula and rotate the lens carefully. In such post-vitrectomy cases, usually combined with some challenging conditions such as large fluctuation in anterior chamber and capsule, lack of visual support, or poor lunar instability, and so on. However, as long as we keep the focal tip in the pupil center to emerge by the nucleus, avoiding catching the capsule, we can see the anterior chamber remains very stable under high vacuum status, even in occlusion break. Because of very deep anterior chamber and lack of visual support, we need to manipulate IA handpiece deeper to engage the cortex beneath the anterior capsule, especially those at 6 o'clock area. After filling with adequate OVD into the capsular bag, in this case, I inserted a -1 diopter and F30 and rotate to the axis I planned. This patient achieved very good visual acuity after the surgery, 1.0 J2. She said she had ever seen this world so beautiful since she was 30 years old. The second case is also a high myopic patient. This patient had bilateral LASIK surgery 5 years ago. The actual length was greater than 31 mm. Pre-OP BCVA was 0.3. In this case, I choose a 15 diopter and F30 by using the Sharma's formula. This patient achieved very good visual quality after the surgery. No halo, no glare, and no flare. The next case is 70 years old female patient with primary angle closure for more than 10 years. The ACD was only 1.77 mm. The OP BCVA was 0.3. Because of very limited working space, I should manipulate the chopping technique very carefully and gently to avoid touching the endothelium and damaging the capsule. I usually fragment the nucleus by using high vacuum up to 700 mm of mercury before use the fecal energy to prevent the endothelium damage, especially in these very shallow anterior chamber depth cases. We can see the CDE is around 2. Carefully remove the cortex, also under high vacuum setting up to 700 mm of mercury. Finally, I insert and rotate the Mplus IOL just as usual. This patient achieved an amazing result from the first operative day, 1.0 and J1. The next case is a 62 years old male patient with dense PSC. Pre-OP BCVA was only 0.2. We can see an obvious posterior polar plug from the OCT image. In such cases, I would like to choose black to minimize the pressure on the capsule. I also perform hydrodissection and rotate the nucleus just as usual, but very carefully and gently. Many surgeons are very afraid of this procedure. I usually chop the nucleus into smaller pieces to minimize the anterior chamber fluctuation. Then fragment the nucleus also under high vacuum setting. And we can see the CDE was 0 in this case. Such dense PSC cases usually combine with zonular or capsular instability. So we should insert and rotate the Mplus more carefully and gently. This patient also achieved an amazing result after the surgery, 1.0 and Z3. The last case is a 76-year-old farmer with intumescent dense nuclear sclerosis. This patient lives in the country of the South Taiwan. He suffered from bird vision for several years, but he had been rejected for cataract surgery by many ophthalmologists before he came to my clinic. Some doctors said his cataract was still incipient, so no need to do the cataract surgery. While some doctors told him that his eye was hopeless, so it was not worthy to do the cataract surgery, not to mention the previous IOL. After carefully completing the phaco emulsification procedure, Mplus is my first choice if the patient asks for a presbyopic IOL. After carefully insertion and rotation the Mplus, just as usual, I always polish the anterior capsule by using a polisher to prevent the anterior capsule shrinkage. This patient was very happy after the surgery, 0.5 and Z7. In the past 8 months, I have been performing 1,025 cataract cases. In these cases, I implanted 266 Mplus out of 320 presbyopic IOL. In these Mplus eyes, the UCVA for FAR, on average at the first post-operative day, there are more than 78% better than 0.9 by using the MF30, 89% better than 0.9 by using MF15. For near, there are 91% better than Z3 by using MF30, and 88% better than Z3 by using MF15. The BCVA for FAR at 1 month after surgery, more than 90% of eyes are better than 0.9, both in MF30 and MF15. And more than 90% patients using Mplus feel satisfied subjectively post-operation. My conclusion about the Lentis Mplus, I consider IOL implantation is not so difficult than initially thought. We can see implantation and rotation the Mplus to the axis I plan takes only 17 seconds to complete. Besides, results are much better than traditional presbyopic IOL and suitable for most of the complicated cases. This is my surgical team and consulting team and my operation room. And thank you for your attention.